I'm Chris Holder. I'm the IT manager for the Department of Molecular and Human Genetics at Baylor College of Medicine, and I'll be your host for tonight's Evenings with Genetics webinar. This webinar series is open to the public and established for families and patients who have a desire to learn more about their conditions. During the webinar, you can enter questions in the Q&A box at the bottom of your screen. I'll moderate the discussion for the questions after the presenters are done. We are also providing real-time translation into multiple languages. If you'd like to pull out your phone and scan the QR code on your screen or join the link in the chat, you can follow along with text translation or actually listen to the spoken language. Our presenters tonight are Farah Ladha, genetic counselor in the Cystic Fibrosis Clinic at Texas Children's Hospital. Pam Tuley has been a pediatric nurse for 34 years and the CF program coordinator for the past 9. Dr. Fadel Ruiz is a pediatric pulmonologist at the CF and the CF Center director. And finally, our parent advocate tonight, Lauren Ortiz, who is a patient advocate and also living with cystic fibrosis.
Okay, hi, good evening, everyone. Thank you for joining us today. We'll be presenting on cystic fibrosis from basics to the future of care. And I'm a genetic counselor, so I'll be focusing more on the genetic side of things. But as Chris mentioned, we have a panel of speakers today. Pam Tuley, the clinic coordinator, Dr. Ruiz, the center director, and Lauren, a person with CF. So when it comes to the topic of cystic fibrosis, we could spend hours, talking about the different aspects of it. But for our presentation today, we're going to focus on the genetic basis of cystic fibrosis. Pam will talk about newborn screening and the pediatric to adult healthcare transition process. And then Dr. Ruiz will talk about current treatments and future directions. There will be time towards the end for Q&As. So if you think of any questions, we encourage you to write them down so we can make sure to answer them tonight. I'm going to start by talking about the genetic basis of cystic fibrosis. I'm also going to tell you a little bit about the history of CF and what we have learned over time. So cystic fibrosis has been around for decades. In fact, the condition was first characterized back in 1938. So this is long before the gene was even discovered. And the Cystic Fibrosis Foundation actually formed in 1955. So there's a story of the 65 roses that's near and dear to us that are aware of this term being used in the community. But this is a story that goes back to around the mid-1960s. There was a young boy around 4 years old, and his mom was always on the phone talking. She was working as through the CF Foundation, and this young child did have CF but didn't know about it. And he kept hearing his mom on the phone, and one day he told her, "I know what you work for." And she was a little bit taken aback because she hadn't spoken to him about his condition or what CF was. So she asked him, "Oh, what is it that I work for?" And she responded by, or excuse me, he responded by saying, "You work for 65 Roses." So since then, 65 Roses is kind of a term that's been used by younger children who can't quite pronounce cystic fibrosis just yet. So now let's talk about what cystic fibrosis actually is. It is an inherited genetic condition that affects many parts of the body, most notably the lungs and the gastrointestinal system. It's caused by a buildup of mucus that can lead to a variety of health issues. So what we're looking at here in this photo is a picture of the lungs. And within our lungs, we have our airways. In the healthy state, our airways are open. Air is able to flow through easily. There's nothing obstructing it. There's nothing getting in the way. But when a person has CF, there's this buildup of mucus that's thicker and stickier than typical mucus. And this obstructs airflow, resulting in a variety of different symptoms. Most of the time you start seeing these symptoms really early on in childhood. So that's why most early children are diagnosed in early childhood, but we can sometimes see symptoms that pop up later into adulthood. CF is caused by genetic changes in the gene called CFTR. This results in a protein that our body needs that isn't able to work as efficiently. And because of that, we can see a variety of symptoms that affect the entire body. We talked a little bit about the lungs and how the mucus can interfere with the airflow, but along with things like breathing, the lungs can also be affected due to risk for different types of infections. With CF, other major issues we see are in the GI tract. We might see some blockages. Sometimes you could see this early on. So let's say when a person is pregnant and through the prenatal ultrasounds, we see some of these blockages. Sometimes we see them right as soon as the baby's born. And aside from the GI issues, something else that's important is the function of the pancreas. So in our body, our pancreas produces enzymes that helps us break down food and to absorb nutrients. When a person has CF, the role of the pancreas could be changed. And because of that, we see symptoms like difficulty gaining weight, poor growth, and malnutrition. One of the earlier symptoms and signs of CF is the salty tasting skin. And since this is one of the earlier signs that we might see in a child, this led to the development of a sweat test being used to help diagnose cystic fibrosis. Along with all of the other body systems that may be impacted, something we see in young adulthood is things like delayed puberty or issues with the reproductive system, such as male infertility. You may be wondering, how common is it to have CF? Right now, globally, there are about 100,000 individuals with CF that we know of. And here within the United States, the estimated number is around 40,000. We can say now that about 1,000 new cases of CF are diagnosed each year. And because of newborn screening that's in the United States, as well as some other countries in the world, most people with CF are diagnosed before they're age 2. And CF is a condition that can affect people from every racial and ethnic background. It was previously thought that CF only affects people of European ancestry, and that's certainly not true. In fact, in our clinic, our patient population reflects the diversity we have here in Houston. So about 30% of our patients self-identify as Hispanic, and about 10% of our patients self-identify as African American. Now, the gene that's responsible for cystic fibrosis was discovered in 1989, and it is the cystic fibrosis transmembrane conductance regulator. And that is a mouthful, so we just say CFTR. So just like all our genes in our body have a particular role or particular function, the CFTR gene has a function, and that is to develop this protein here. And with this CFTR gene, there's a lot that we've learned over time. When we think about genes and how they work, something that's important is the location. So really breaking down each part of the gene. There is a code, a genetic code that we look at when we think about how genetic changes happen. So, the instructions of our body, you can think of this as a typo or a change in the blueprint. The most common genetic change or mutation in the CF world is the F508del or Delta 508. This picture is showing more of the more common variants that are out there, but as of now, there are probably about 2,000 different mutations that we know of. Something that we've learned over time is that the specific location of the mutation can tell us how it impacts and changes the way the protein works. So if you see this color bar right here, this coincides to what part of the protein it changes when a mutation happens. When it comes to treatment and medications for CF, some of them do depend on the specific mutation a person has. With CF, this is caused by 2 genetic changes. So oftentimes we're looking at 1 or 2 different combinations to help figure out what effects we're expecting to see in the body. And one example could be based on the combination of mutations that could tell us whether someone is going to have issues with the way their pancreas works or not. Looking a little bit more into the CFTR protein, this is this large channel that we're looking at right here. So the job of the CFTR protein is to allow the passage of chloride in and out of our cell. And this balance is important because where chloride goes, water goes. And going back to the example of mucus buildup, in the cells of our lungs, it's important for mucus to be cleared out and taken out of the way. So these hair-like structures that you're looking at here, the cilia, this help our cells help get the mucus out of the way. But when the chloride channel is not working, water is not going where it's supposed to be, the cilia is not working as it should, and this leads to this buildup of mucus that can cause many different health issues as well as a buildup of bacteria, which is what we're looking at here. CF is a very complex condition. You know, we often say that no two people are going to have the same types of symptoms. Thinking about the types of mutations or possible genetic changes a person can have, it can get very complex. So I want to give a brief overview of the different types of mutations that can be possible. Looking at this picture on the right, when the gene for CF is working properly, the CFTR protein is able to be made, as you can see here, and it's able to go to the end of the cell membrane, and there's a clear flow of the chloride ions in and out. Now, this picture here is going to show different levels of where changes can happen if someone has a mutation in this gene. Starting at the bottom with class 1, when there are mutations in this classification, your cells just don't make the protein. In class 2, what we're looking at here is a protein is being made, it's just not folded correctly. In class 3 up here, the protein is made, it's able to get to the cell membrane, but it just doesn't work. There's some type of defect. With class 4, the protein is made, it works, it just doesn't work as well as it should because there's some type of misshape that's the shape, it's just not as correct as it should be. With class 5, your cells do make the protein, it's just not as many as you need. And with class 6, the protein is being made, it just doesn't live in your cell as long. So when we think about the medications that are available right now, one category are called CFTR modulators, and their job is to help restore the function of these proteins. As you can imagine, these type of medications don't work in patients that don't actually have protein being made. So for those that are in these categories, these modulators are really helpful to help the CFTR protein do its job. And for those that are in these other categories, there are a lot of research studies being done to see what options we have for medications that can help. Let's talk about how CF is inherited now. As I mentioned, CF happens when there are changes in both copies of the CFTR gene. When a person has just one change in a CFTR gene, whereas the other copy of the gene is normal, that's when a person is called a carrier. So when two carriers get together and have a child, there's a 25% chance or 1 in 4 chance that that child is going to have CF. There's a 50% chance of having a child that's going to be a carrier that does not have CF. And then the remaining 25%, 1 in 4, will be for a child that is not a carrier and will not have CF. So these risks are for every single pregnancy. So just because parents have one child with CF, it doesn't mean that the rest of their children will be unaffected. These are the numbers we're looking at for every pregnancy. With updates in treatment, specifically with a medication called Trikafta, we are now seeing a large population of individuals with CF start families of their own. And thinking about when a person has CF and they have a child with a carrier, that results in a 50% chance of having a child with CF and a 50% chance of having a child that's a carrier. So if a person has CF, it's important to have these conversations and to talk about carrier testing for their partner. Something that's very interesting that we have seen more recently is when a pregnant person is taking Trikafta, this medication can be transmitted through the mom's bloodstream and through breast milk when they're breastfeeding. And what we're seeing is that if a baby born to a mom taking Trikafta has CF, they end up having a normal newborn screen, possibly fewer symptoms or maybe not even any noticeable symptoms when they're born. And if, when we have sweat tests being done, those can often result with a normal result as well. So what each state is doing, Texas included, is trying to learn more about these cases and come up with guidelines for management and recommendations for babies born to parents with CF taking these special modulators. When it comes to being a carrier for CF, again, that means having one genetic change, whereas the other copy of the gene is normal. It's pretty common in terms of these type of genetic conditions. So if no one in your family has CF, your chance of being a carrier depends on your racial or ethnic background. You might see different numbers floating around, but these are the general risk numbers based on racial or ethnic group. So for someone that is white, non-Hispanic, they have a 1 in 25 chance of being a carrier. Someone that is Hispanic has a 1 in 58 chance. African Americans have a 1 in 61 chance, and Asians have about a 1 in 90 chance of being a carrier. So it affects, based on the data that we have, it affects each ethnic group. It's just the frequency is a little bit different. And most of the time, being a carrier is not going to cause any symptoms because carriers have that extra copy of the gene that's working normally. Something that we have been seeing, however, is that some people that only have one change in this gene, so being a carrier for CF, might have symptoms like sinus issues, maybe pancreatitis, and we might see male infertility as well. When it comes to genetic testing for CF, there are several different options available. Newborn screening is widely implemented across the United States, but not all newborn screens are going to be looking for the same thing. And in Texas, our newborn screening for CF started in 2010. So if there was someone born before 2010 and there's a concern for CF, it's important to do genetic testing, looking at the full gene, looking for spelling changes or deletions or duplications. Sometimes when we order genetic testing, it doesn't always pick up an answer. The good thing is that there are a lot of research programs, including one through the Johns Hopkins, where they're able to do more analysis of the gene, looking at hidden regions, looking for rare mutations that might not be found through your standard diagnostic genetic testing. We have also talked about carrier screening. I want to mention that carrier screening can vary depending on who's who's ordering the tests. Thinking of the mutations that I showed earlier, some carrier screening tests only look for the more common variants, maybe about 25. Some might only look for 100 variants. So if you or your partner is a carrier for CF, we recommend having a prenatal genetic counseling consult to talk more about which testing options are right for you and your family. There are also many options for preconception genetic testing, so before a pregnancy is achieved. It's also important to talk about the options that are available to you once a pregnancy is achieved. And if you do have a positive family history of CF, it's important to discuss this with your healthcare provider. Depending on the particular type of mutation that's running in the family, it's important to make sure that the test you're having is going to test for that specific variant. If you're looking to find a genetics provider near you, these are the two options I'd recommend. They can tell you about telemedicine video clinics as well as in-person clinics with whether it's a prenatal, pediatric, or adult type setting. And I want to end my section of this talk by talking about the theme of this year's CF Awareness Month, and that is resilience. I talked about the way the genetic basis of CF, an example of the many symptoms that a person with CF could be facing. And as you can imagine, living with CF can come with unexpected obstacles and challenges. However, the CF community's ability to navigate through these difficult moments in their day-to-day life really shows their determination and resilience. There will be time for questions at the end. My email address is right here if you need it. Thank you for your attention for my part, and I'm going to pass the mic over to Pam now.
Okay, so my name is Pam Tuley, and I am the clinical program coordinator for the CF Center here at Texas Children's Hospital. And I'm going to talk a little bit about screening, newborn screening, how and diagnosis and transition. So babies in the past, before we had newborn screening, they would often present with very severe malnutrition, failure to thrive, electrolyte problems. And so now that we have incorporated CF screening into the newborn screen, we're catching these babies much earlier. And then also, if you can diagnose them earlier, you can start treatment and kind of catch them before they get sick, so that you're not behind the 8 ball trying to catch up and gaining weight when they're already having problems. So, and obviously that's going to improve clinical outcomes in the long run. So our goal is always for babies to be have their care initiated before 30 days of age. So that's why newborn screening is so important. Okay, so just a little history on newborn screening. Obviously, the newborn screening, otherwise known as like the PKU test, has been going on for many years. But back in the 80s, Wisconsin and Colorado began doing a pilot program to add CF screening to the newborn screen. Unfortunately, Texas was the last state to join in with all the other states, and we started in December of 2009. So we were a little late to the party, but we're finally there. So not every newborn screen is created equal, but here in Texas, we're called an IRT DNA state. An IRT stands for immunoreactive trypsinogen, because we love our initials in CF. And what it is a protein that's comes from the pancreas that is elevated in babies with CF. There are other reasons it can be elevated. A baby is premature or had a stressful birth or has some congenital issues, infections that can also cause the IRT to be elevated. So it's a screening tool to identify babies who are at risk. So so here's what Texas does. Since we're IRT DNA, we start out with the first newborn screen at about 24 to 48 hours after birth. If the IRT is elevated or normal, then great. If it's elevated or very elevated, they don't do anything with that. Then the next newborn screen they get about 2 weeks after birth. That one is a normal IRT, then great. Normal newborn screen, no worries. But if it's elevated or very elevated, then it gets sent for genetics to the lab to look for any of the CF mutation panel of 60 mutations. So not all the mutations, but enough that we feel like they can at least catch, the net is wide enough that they're going to catch most of the babies with CF. So you get an elevated IRT or a very elevated IRT, several scenarios can happen. A baby with 2 mutations obviously is very likely to have CF, depending on the mutations, but it's presumptive CF diagnosis. Those babies will be referred for sweat testing. A baby with 1 mutation will also be referred for sweat testing because it's possible that the baby has CF, but they weren't able to identify another mutation because it wasn't on the panel. Babies with elevated IRT 0 mutations, that's a low risk, and they're not considered they're not referred for sweat testing unless they start exhibiting some kind of symptoms that are suspicious for CF. If a baby has a very elevated IRT, It really doesn't matter how many mutations you have, you're going to get referred for a sweat test. But obviously, that 2 mutation baby, I receive those newborn screens, all the ones that are abnormal for the Houston, Beaumont, up to Lufkin, down about halfway to Corpus. So those come to me, and so my job is to work with the state to make sure that those babies are being sweat tested. So here's an example of a newborn screen that a pediatrician would receive. This is the bottom half. And so these are all the other disorders that you would see. And then the CF category, you're going to see an elevated trypsinogen, IRT, and then they send it to the lab because this is the second screen, and they found 2 mutations. And down here, they told us that the baby had 2 copies of the same mutation, which is the delta F508, which is the most common mutation. Next possible scenario being the elevated 1 mutation. This baby also needs a sweat test because there could be another variant that's not included in the panel. And then this is a newborn screen that's technically normal in the eyes of the state, an elevated trypsinogen, and no mutations detected. So they recommend that you don't need another evaluation unless the baby's starting to act a little suspicious. So newborn screening is screening. It's not a diagnostic test. You've got to follow up any kind of abnormal newborn screening with a confirmatory test of a sweat test. The sweat chloride test is the gold standard to confirm the diagnosis. And it's also important that we do that sweat test just in case, errors can happen in newborn screening. I've never actually seen it happen, but it can. And so we perform the sweat chloride test, which is a measure of the sweat in the baby, measure of salt chloride in the baby's sweat. So these are the numbers that we use to determine whether or not a child has CF based on their sweat chloride test. 29 or less is normal. 30 to 59 is intermediate, and then 60 or above is considered abnormal, and that child would be considered positive for cystic fibrosis. There's some minimums of age and weight, because some babies, if they're really small, don't weigh very much, they won't sweat very well. And sometimes when we get babies who are already having symptoms, it's very difficult to get a sweat test. So, but we don't wait. If we get a 2 mutation baby and we can't get a sweat test, we're still going to treat that baby like they have CF presumptively, because you're not going to wait just to have a positive sweat test. So this intermediate is and basically is going to need a little more evaluation to find out what's really going on. And those are typically our 1 mutation babies that we don't know if they have another one, but they have a sweat test that isn't negative, but it's not positive. So since we started adding CF to the newborn screen since 2009, this is some of the information we got from the state. And since then, up to last December, they have diagnosed 788 cases of CF in infants born in Texas who had their screening done. And it looks like they screened 9.8 approximately baby screen. That's a lot of babies. I'm pretty amazed. But this kind of gives you a breakdown of, who had 2 variants on their newborn screen, who had 1. And then over here, this is a little bit kind of interesting, the number of missed cases. And obviously, that happens. But the numbers are pretty small. And, considering that they analyzed 70,000 babies, for their DNA, and 5,300 had presumptive positive, that's pretty good. So, and we always investigate, we always follow up, and they do follow these patients and keep this information. So once a baby has had an abnormal newborn screen, it's essential that they have a sweat test done at an accredited CF center. These are places where there is specialized care, specialized training, pulmonologists who have expertise in CF. So we are an accredited CF center here in Houston. We're the only one in the Houston area. And what part of being accredited is you're required to have um, people on your team that can participate in that patient's care, because they don't just need a doctor and a nurse, they need respiratory care, they need a dietitian to manage their nutrition. There's a lot of social issues that can happen, you know, insurance problems, mental health concerns, things that a social worker is needed for, and they're highly engaged in our families' care. We also have access to psychology. We have a great pharmacist. We have our wonderful genetic counselor Farah, and then all the medical subspecialties that you know, we have access to those that anyone who might need: GI, ENT, the, things like those kinds. Endocrine. So CF is a chronic disease. It is lifelong. There is not currently a cure. So basically the foundation, once again, being part of the foundation and being accredited, we are obligated to follow their guidelines. And the guidelines require that patients be seen by a CF specialist every 3 months. So we call these the quarterly visit. And in each visit, they're going to be evaluated by the pulmonary doctor. They're probably going to have a nutritional assessment, you know, if weight is an issue at that point. Everyone gets a sputum culture, which is a routine surveillance of their lung microbiology. So we know if they're growing any particular types of bacteria that we need to know about. And then checklists: social worker, RT, pharmacist, dietitian. They do at least once a year. They evaluate what's going on with the family, what's going on with the patient, and places that identify needs, make sure everybody's on the same page. So not only do we see our patients, you know, quarterly for surveillance visits, we also have you know, they do come in when they're sick and having, you know, a pulmonary exacerbation or perhaps a GI problem. As Farah mentioned, that the lungs and GI system are likely to be the two most affected systems for a patient. And so they do have problems that we need to address. Patients, you know, there's evidence that the patients who make those quarterly visits have better outcomes. Their FEV1 is higher and their BMI is better. So, you know, that's why the foundation recommends those visits. So just for your information, there are 10 accredited CF centers in Texas. We're one of them. And then there's Dallas at Fort Worth, Austin, 2 in San Antonio, Tyler, Corpus, Lubbock, and Temple. So they're all great, and we're glad to have them. So, you know, now that care is improving, we're diagnosing earlier, we have some amazing medications that are helping patients live longer, better, more, you know, healthier lives. That there in 2021, there was a point where there were more adults with CF than there were kids. So that's a pretty fantastic place to be. So, and that's only getting better. And Dr. Ruiz will talk a little bit about, you know, where the trends are going and in medication and treatments and therapies. So now that we've got these older patients that are growing up, they need to transition. They need to go to adult care. And thankfully, we have our own adult center down the street. And so our goal is to prepare patients and help them develop a sense of responsibility for themselves, and not, not do everything for them, and help kind of, as time goes on, push them into, adulting a little bit. So when we're trying to transition patients, it basically starts at birth. I tell our new families, one day your child is going to go down the street to the adult center. So they know about it from the beginning. But we have to have formal plans, because it's, you have to have a plan, or you're asking for trouble. And you want to frequently assess kind of where you are and where things are going, and are they going in the right direction? And you've got your whole team. Everyone needs to be engaged in helping this patient become ready. And also, obviously, you need the patient and the family, as well, to be motivated and engaged and proactive, and kind of, part of the discussion, because they need to have some input on that, and figure out where, what we need to work on. And you have to be persistent, and you have to talk about it, as often as you can, just to keep it in mind. So, we have, like I said, our wonderful adult center down the street. And we're actually one care center with two programs. So the adult and pediatric. So our adult center, our PD center, we have about 388 patients here at Texas Children's. And then down the street at the adult center, they have about 350. They work out of the McNair campus of St. Luke's. It's down the street, really nice new buildings. And so they've got a great place to, it's very close, which is really, really nice. And, obviously, to have plans in place and to make sure that transition goes well. We created a committee back in 2006 to help standardize processes, make sure that we were addressing the patients who, were approaching transition age, making sure that each of them, was on the path and headed in the right direction. We meet twice a month, the pediatric team and the adult team, to talk about the patients who are about to transition, and those that are kind of on the launching pad, that we have an idea of when they may transition, and to make sure that we've gotten everything taken care of. And so in that committee, we also, we talk about ways to make the transition process better, help to ensure that our patients are as prepared as they can be, and eager, to get out into the adult world. We talk about, each patient as a separate person, and what kind of barriers they might be having. Traditionally, insurance has been probably our biggest barrier when kids are turning 19 and 21, and trying to make sure that they have insurance and that they can keep it. And then just motivating the faculty and staff to, support the recommendations, and making sure that we have a successful transition program. So that is the end of my talk. There's my email address. If you have any questions, I'm happy to answer. And I think Dr. Ruiz can take it from here.
Well, good evening, everybody. My name is Fadel Ruiz. I'm one of the providers for the center here in Houston. It's a great honor to be here sharing with you guys. And thank you, Pam and Farah, for that wonderful introduction they've done so far. So I was tasked with talking about treatments for CF. Where have we been? What are the results of those treatments, and what are we doing going towards the future? I have been a speaker for Vertex and get some support from the CF Foundation. Those are my conflicts. So when we look at cystic fibrosis, one of the most important points is the pulmonary health that patients have. A decline in their lung function is going to be what makes them really sick, and that the thing that can shorten life expectancy. And you can see in this graphic that we have come a long way in the three different age groups. If you look at the younger kids, those that are 10 years of age, their FEV1, 100 is, let's just say, perfect. You want to be at 100%. In 2001, kids with CF of that age were only able to achieve 87%. In 2021, with all the different things that we've been doing in regards to treatment, it was 100%. For older kids, and the older than you get, the greater the chances that you're going to have more advanced lung disease. So you can see that the lung function for those that were 18 was obviously lower than in the younger kids because they were older, but then had in 2021 almost close to normal at 96%. And for those adults 30 years and older, it was almost half of what it should be. But look at now, in 2021, almost 3/4 of what it's supposed to be. So a significant improvement over those 20 years. And because of all of that, because we are able, with all the therapies that we've been using, and we're going to touch bases a little bit, we've been able to improve the life expectancy. If you look at in 2002, it was about 36 years. That means that half of the people used to be alive at that time, and half of the people had passed because of CF. But in these 20 years, we've been able to add 20 years to the life expectancy. And now the life expectancy is 56. It's still below the normal life expectancy of somebody without CF, but making great stride and looking forward with all these new medications and new research that is going to continue to improve the life and the quality of life of those people with CF. Prior to the modulators, and Farah and Pam already talked a little bit about all of this, the way that we used to treat, and we still do in those patients that are not eligible for modulators, we used to use these symptom-based therapies. Very successful, as you saw, the improvement in the life expectancy and the improvement in the pulmonary function, and it improved the quality of life, right? It was focused mostly on treating the symptoms. So you have pancreatic insufficiency, you treated that so the patients did not malabsorb and they were able to gain weight. If you had a lot of cough, productive cough, you treated those symptoms to kind of mobilize secretions and prevent pneumonias from happening. But again, like I was saying, the mean predicted survival remained well below that of somebody without CF. Part of the pillars of the things that have helped us reach that improved patient survival were based on evidence-based strategies that then were disseminated as through the different centers by the CF foundations. And part of it, we've been hearing about it, the neonatal screen program, diagnosing patients early so we can start treatment early. For those who have GI problems and malabsorption, getting pancreatic enzyme replacement, being seen in a specialized CF care center, as Pam was talking about, giving complete nutritional management, so very healthy diet with supplements, increasing the chest physiotherapy to make sure that the secretions that accumulate on the lungs don't cause as minimal possible of a damage as possible, and to use aggressive antibiotic regimens for those bacteria that Pam and Farah was talking about that we need to detect as early as possible. So a lot of what we do is treating the complications of the lungs. We know, like Farah was saying, we have the gene defect that then leads to that protein that is abnormal, that then eventually lead to that dehydrated airway surface, right? And then what happens is that you get into this big circle of symptoms in which you're going to have mucus buildup that is going to lead to infection because the bacteria love to live in that environment. And then when the bacteria and our own defenses start fighting with each other to kind of prevent the bacteria from giving us problems, they create a lot of inflammation. And that inflammation then continues that circle and gets going and going until it leads us to advanced lung disease. So a lot of the things that we do is to improve the mucus clearance, to use antibacterials, and to use anti-inflammatories to prevent this circle for being active all the time. We have come a long ways. If you see from the early 1900s, when we barely started treating the symptoms of malabsorption, then we started using antibiotics specific for Staphylococcus aureus, then we started doing chest physiotherapy. And you see that this has been at different steps of that ladder that had led us to now what we do with the modulators and all that. And with each new step that we took to improve the care, the survival and the median predicted age was improving and improving. So we do symptom-based therapy. We continue to do that. But now we're trying to be more specific about how we treat the particular genetic variants that each patient has. How do we treat that mutated CFTR gene? And then we know that there's 3 different ways in which we're going to do that. We have to be able to repair that protein, we have to be able to restore it, or we have to be able to fix or replace it. We're already repairing it with the use of modulators. But in order to do that, you need to have protein. For those that are not able to make protein, then we need to either restore that protein or either fix it or replace it. So we know that when protein is made, then the modulators can help. And thank goodness, 90% of the population in the US now is eligible for modulators, right? But the mutations don't go away. They're still going to be there, present in the DNA, the RNA, in the protein. The only thing that the modulators do is change that protein function. So for example, the delta F508, that is the most common mutation like Farah was talking about earlier. What happens is that the protein doesn't fold the way that it's supposed to in that nice graphic that you see here. So a corrector like the tezacaftor and the elexacaftor helps that protein fold by then correcting where that variant affects the way that the protein folds itself. But then not only that, we need not only for the protein to be there, but we need for that protein to work. And sometimes what happens is that you make it and it doesn't work as actively as it's supposed to be. And that's when we need to use the other part of the modulators that is called a potentiator, right? And that's going to help the CFTR protein open and close. Remember that this is mostly a chloride channel, has other functions as well. But by allowing that chloride channel to work properly, then it affects the way that the CFTR affects and causes symptoms in patients with CF. I say that I'm blessed with the fact that in my lifetime as a physician, I've been able to see a medication not only participate in the research to lead us to be able to use it in patients, but also to see the use of these medications used in patients with CF. And it's been life-changing for those that are eligible for CF. It's transformed CF care from the perspective Pam was telling you that now more adult than pediatric patients exist in the US. That's good. We pediatricians are going to be out of a job for CF. No, not quite. But, we're always going to have pediatric patients, but now we're satisfied with the fact that the great majority of them are going to survive and going to lead adult productive life. However, when you see here is there's still about 9 to 10% of the population are going to have mutations or variants that are ineligible, or we're going to have a small percentage of them as well that are going to have side effects related to using them, and they're not going to be able to use it. And when you look at those, the majority are either splicing variants, and Farah is pretty excited about looking at all of this, but those are variants that basically affect the protein doesn't get made, and then that's a big problem. The other thing that is important is that a lot of the patients that fall in this category belong to minority groups. A great percentage of them is from Hispanic or African American backgrounds, and it's going to be important to not leave anybody behind. That's one of the mottos that the Foundation, CF Foundation, and the CF centers have, that we want to make sure that all patients with CF receive the care that they need. So, but like I said, we started first with use a potentiator that only 10% of the population was able to use, but then through research and the development of the different compounds, we've been able to get modulators that are better and better. Basically, what they do is they improve the function of the CFTR protein, and you want to improve that by a significant percentage. And if you see that with the first, the second generation of modulators, we were above the threshold that of 40% of the function, and then even higher, up to 60% of the function, and higher than that furthermore. And then by improving the CFTR function, then what happens is that you're going to get better pulmonary function results. And they have created changes from all different perspectives: prolonged survival, better lung function, less pulmonary exacerbation, so patients don't get admitted to the hospital. In the past, we used to have 10, 15 patients admitted to the hospital with CF with a pulmonary exacerbations. Nowadays, we may have 1 or 2 at the most. They have a significantly decreased rate of lung function decline, which is one of the things that we want to get. More people with CF are getting pregnant and having kids, like Farah was talking about. And then the younger patients are also preserving that pancreatic function in some of them, which allow them to have much better nutritional outcomes. Just to give you an example, this is one of our patients who had severe advanced lung disease prior to starting on Trikafta. The lungs are full with air, so they're supposed to look black. So when you see all these white spots in there, it's because there's a lot of injury within the lung, a lot of mucus buildup and all of that. And then you can see that this patient was pretty sick because he has a port, right? That means that it was requiring antibiotics very frequently. And because it didn't have any more veins in the arms and all that, we needed to put a port to deliver the antibiotics that way. And then after 11 months, less than a year of being on Trikafta, look at the big difference, more on the left lung. Look how all those white spots and all that start to fade away. They look significantly better. And that was reflected also in improvement in the pulmonary functions and improvement in the weight. This patient was had issues with gaining weight and all that, even with providing supplements, with giving good pancreatic enzymes and all that. But this patient was able to gain 35 pounds over 19 months. And the body mass index that was below the 1% was able to improve all the way to 37%. So something marvelous, an incredible change from the perspective of how it affected patients. However, like I was saying, there's always challenges, right? A medication that you have to take every day, even as good as a modulator, sometimes we forget to take it, right? And sometimes because we feel really good, we have to continue to do those other therapies, but then we say, oh, I'm feeling much better, I'm not gonna do them. So we stop doing the breathing treatments, we start doing the airway clearance methods and all that. Some people had really bad side effects and then we had to stop them. If you have liver problems, those medications are metabolized in the liver, and sometimes you have to work with that. Sometimes it causes too much weight gain, something that is really, really good in the majority of patients, but we go to the other extreme. Now we have patients that tend to be overweight or obese, and we have to deal with the complications of being overweight or obese. Sometimes we can have mental health changes. There's significant drug interactions with other medicines that we have to always be checking to make sure what medications are in there so that they don't fight each other. And we need to constantly monitor to kind of make sure that first we don't lose efficacy, and also that we don't increase toxicity or other adverse effects related to using these modulators. So if you see, this is in this pie chart. So we have people that are full responders, that is the majority of the CFTR modulators. We have some of them that have not as good a response because not everybody responds the same way. The majority of the people respond really well, but there are some people that respond to a lesser degree to these modulators. We have a group that is considered the intolerant group, those that have the ineligible variants. And remember, like Farah was saying, this is a disease that is seen in other parts of the world as well. And in the US, we are blessed with the fact that we have access to all these modulators, but in the rest of the world, they're still fighting to try and get access to this super important medication. And so that's an issue. And even here within the US, sometimes we have patients who may not have insurance or may have difficulty obtaining this kind of medication because it's a very expensive medicine. So modulators, not eligible or intolerant or anything like that, and also eventually what is going to lead us to a cure are going to be the genetic-based therapies, right? So we're exploring different strategies of how to correct that copy, or either the messenger mRNA or the DNA. So we want to affect it at the nucleus level, right? And we are going to do that either by providing the correct genetic instructions to the cells to be reprogrammed into making a functional CFTR protein. So we said when proteins are made, modulators help. Now, when no protein is made, then the genetic therapies are going to be the ones that help. And this includes all those mutations, and you don't have to remember that. But these are basically the mutations that by being there, then there's no protein that gets made. And we can go different ways. We can do something that's called gene editing, or we can do short nucleotides for mRNA therapy. And eventually the goal is gene therapy that is going to specifically, put DNA particles in there. These two are a little bit further away from being developed. The ones that we're already working on are the nucleotide-based therapies right now. So we either gonna go with gene transfer or gene editing that is gonna allow us to deliver the DNA into the cells, into the particular organ. Most likely we're gonna start with the lungs, but we still have to figure out things like what vehicle are we gonna use to put those cells inside of the lungs? For how long are they gonna be able to be there? Do we have to do it repeated once, just at one time, or do we have to repeat this once a year or every 6 months or every month? And which way are we gonna do it? Are we gonna do it through an IV? Are we gonna do it through an inhalation? So all those things are research that is ongoing. And then what are gonna be our target cells, right? You're not gonna be able to correct all the cells within the lungs. You're gonna have to specify which cells in particular and what specific organs are gonna be the ones that are gonna be needed to then reach the results that we want. But the thing that we can say is that the researchers and the CF community keeps fighting because we want at some point and hopefully be able to say that CF stands for cure found. So in summary, we wanted to say that cystic fibrosis is a genetic disorder that affects all races and ethnicities. The CFTR is the protein that gets affected, that early diagnosis is possible by newborn screen, that the majority of the patients survive not into adulthood, so a transition process is very important, like Pam Tuley reviewed, and the treatment of CF has improved significantly with the use of CFTR modifiers. And now we continue to work towards genetic therapies, again, with that goal of CF being cure found. So thank you, and I think that we're gonna open it to questions and answers.
Thank you so much, Dr. Ruiz. We're going to pass it over to Lauren now.
Oh, yes, I'm so sorry.
to give her.
Look at that, I got so excited that, yes, Lauren that is gonna speak now to us about her experience of having CF, and all the things that she has experienced in her lifetime, having grown in the CF center in the pediatric side, and then now being seen at the adult center, and all the different experience that she can share with us. So thank you, Lauren.
All right. Thank you, guys. I don't have a fancy slide deck to share, but hope you don't mind. But to share a little bit about my experience, I was diagnosed at about 2 months old. So prior to the newborn screening being a gold standard here in Texas, I was diagnosed for failure to thrive. I wasn't gaining weight like I should have, and they eventually found that I had CF. So it's been a wild ride since then. That was about 30 years ago. I was a patient with the Pediatric Center at Texas Children's for my first 19 years of life, and so pediatricians there, and a really great experience there, the 1821 major age fair. The transition process was, I think it was beautiful for what I needed. It was definitely tailored to who I was, what I needed, what my expectations were. I was going to college at that time, so we decided to defer it for about a year just so I didn't have too many changes all at once. So I continued to see the pediatric team through my first year of college and then transferred over after that. I was able to meet with the adult center a couple of times and see their center back when it was in the Baylor Clinic building on Main. If any of you guys have been around for a while, you know where I'm talking about. And so I felt like I was supported throughout the whole process. I didn't feel like I was being left out to dry, that my pediatric team was just kicking me out the door. It was definitely a process that was well orchestrated, and that I felt like when I finally moved to the adult center full time, I felt like I already knew the people that I was going to, and that they were all still in communication with my pediatric team, and probably even still to this day, about my care and how I was doing, and getting historical context and things like that from them. So speaking of what Pam was talking about, I definitely feel like it's probably gotten even better. I know it has gotten better since the time that I transitioned, and I'm excited to see that you guys are continuing to make that process tailored to the patients, tailored to the families as they transition. We are typically with our pediatric teams for our entire childhood, teenage years, and so leaving them is very difficult. It's like leaving a family member behind. So definitely really appreciate all the work and effort that goes into it from the pediatric side and the adult side. So about me a little bit more. So I went to college, graduated college, and have a full-time job that is more often than not a great opportunity, a great experience. We got married about 5 years ago, and my husband and I had a little girl about 8 months ago, and she is the cutest thing. I'm biased, but she is the cutest thing. And so she would not have happened without Trikafta. I've been on Trikafta for about 5 years now. I started it 2 weeks before we got married, which may not have been the best decision, but when a new med's out there and you're told it's going to change your life, you don't hesitate. So I started on Trikafta, saw an increase in lung function. I saw about a 20% increase within 3 months. I did start it in November of 2019, so that was right before the COVID-19 pandemic. So I actually didn't go to clinic for about 6 months because of that. And so once I did go back, they saw that my lung function had improved. My weight had improved a little bit. I had been on some other modulators over the span of, I think 5 or 6 years as they had come out. And so I had gotten some weight gain from the previous modulator, so I didn't gain too much with Trikafta. But it did cause my lung function to increase even more, which is not something I saw with the other modulators. It really did give me my life back. It gave me my ability to see a future with my then fiance or husband, look at a timeline, and be able to expect to live a normal life. My health was very unstable for a few years there before I started Trikafta. And since then, it's been predictable. I mean, I can go to clinic and basically know what my CFP is going to be within a couple percentage points. We like to play a game and see who gets closest to the number. But it's very predictable. And I couldn't have done that. I've had that experience about Trikafta. And then also my daughter wouldn't be here. We had definitely thought that was not a route for us. We didn't want my health to go downhill. That's what they typically see with adults, with CF, particularly women after they have children. Postpartum is very hard, regardless of CF or not. And you don't really take care of yourself, like you said. So we didn't, we basically convinced ourselves we didn't want to have children because we didn't want to put my health in a state that it could get worse and eventually, not be here, me not being here. So we convinced ourselves we don't want to do that. We don't want to explore that. And then Trikafta came along and changed the game. And a couple of years after starting it, we had a conversation with my CF doctor. We were like, do you have any concerns? Do you have any red flags, any yield signs, anything that you would say you shouldn't do this? And he said, no, not at all. Your health is stable. Your lung function is stable. Your weight is stable. Like all of these things, it's stability left and right. And so she gave us the green light, and then about 6 months later, Ada came along, and I can't imagine not having her in my life, and I'm so thankful we decided to move forward with that. So definitely am grateful to my CF teams, my pediatric team, my adult team for taking such great care of me over the last 30 years. And then also the CF Foundation for developing these new medications, Vertex creating the Trikafta medication. It's been incredible, the change that it's had. So yeah, that's my story. I think, are we going to Q&A now, or am I moderating?
No, we will move on to Q&A. Thank you so much,
Okay.
Lauren, for sharing your story.
Great.
That was fantastic. And for those of you who weren't here early, we got to see her daughter, and she is absolutely precious. We've got a question from Andrea. This is probably for Pam. How does the CF Center address the emotional impact of transitioning from pediatric to adult patients for both the patients and their families?
Well, this might be for Lauren as well. I mean, I feel like, obviously we have our social worker, our mental health coordinator who are that focused in on, emotional needs of our families. I mean, just in general. But I feel like you know, the whole point of transition and starting early and talking about it and working things out is that, you know, we try to reduce that anxiety, that, you know, fear, just by, you know, involving the patient, involving the parents, you know, answering their questions, giving them as much information as they can, as we can. I mean, we can't predict everything, but it's, you know, I feel like it's all about just knowledge and being empowered and knowing that this is, you know, this is your journey. And so we're not trying to tell you how to feel or what to do, but, you know, we're here to support that. But, you know, you're growing up, and that this is good. You know, this is important that you make this step because, you know, you're an adult, and adults have different problems than kids. And, you know, so, I don't, I mean, that's my take on it. I don't, if Lauren has anything specific, you know, she can think of that made you feel like reduce the, I know there's going to be anxiety. I know there's just, that's how it is. But if there's a way that you felt we particularly dealt with that.
Yeah, that's a great, great question. Whoever asked that question. I do think that maybe standing for my pediatric team, you out. If you don't feel comfortable transitioning right now, let's develop a plan so that you feel comfortable. Like I said, I didn't transition until I was 19. I wanted to go here with a team that I knew that knew me, even though I moved 500 miles away. Like I still wanted a team that was going to be familiar. So they understood that. I think, Pam, like you're talking about, very individualized. It's not you turning get a game plan together and reevaluate as we go.
Thank you, Lauren. We have another question from Andrea. What are the key considerations individuals should keep in mind when doing genetic testing to find out if they are carriers?
I'll be happy to take that one. So as I was talking about with the picture of the different mutations that are known in CF, most of the time carrier screening is going to be a limited panel. It might only look for maybe 23 variants. There have been recent recommendations now where they're recommending to look for 100 CFTR variants for carrier screening. Doesn't mean it's actually happening. Sometimes we've seen this happening where a patient or parents say, oh, I had carrier screening done at my OB's office. It was normal. What were they looking for, though? They were only looking for 1 or 2 mutations. So something that is really important to keep in mind is what we call residual risk. So that means that if you have this test and it was normal, what is your likelihood of still being a carrier? So it's important that when you have carrier screening done to actually have a conversation with your provider and ask, just kind of even read the report yourself and see what exactly did it look for. And ultimately, our recommendation is always, or at least my recommendation is always going to be, if you're interested in carrier testing, have a prenatal genetic counseling appointment. They can tell you the ins and outs of the test you're specifically having, and they can help you order a test that might be right for you. Insurance plays a big role. Ideally, we'd like to offer expanded carrier screening to look for all sorts of variants in this gene and others, but sometimes that's just not practical. It's not realistic. So I think just, thinking about your family history, especially if it's positive, trying to get a copy of those reports to make sure your carrier screening has those specific variants.
Thank you, Farah. How long did it used to take to diagnose CF for people who were born before 2009?
I can take that one. So symptom-based diagnosis used to take 1.5 to 2 years. So it was a very difficult journey because it's a rare disease. So pediatricians used to think about different things, right? Or you got reflux, or you have, asthma, you have whatever. And they never really thought initially that this could be cystic fibrosis. So on average, 1.5 to 2. That was even more time for patients of minorities. If you were Hispanic, or African American. The thought many years ago was this was a disease that affected only white people, like Farah was saying. And therefore, if you were Hispanic or African American or any other minority, used to be even less in the differential. And that obviously led to a very late diagnosis and all that. Nowadays, with newborn screening, like Pam was saying, most kids are going to be diagnosed before their 30 days of life, which is a significant change. And it's very important because obviously the earlier you start treating this condition with the proper medications and all of that, including nowadays modulators. Some of the modulators are approved all the way down to age 1 month for certain group of patients who are eligible for that. So it makes a big difference how early you're able to diagnose patients now.
Thank you, Dr. Ruiz. We are at the end of our webinar tonight, so I would like to go out with a message from our former program director for the Evenings with Genetics program, Susan Fernbach. Susan writes to us, "I so appreciate these beautiful presentations. As a retired genetic nurse, this has been such an emotional presentation. One of my dear colleagues passed away from CF prior to all of the discoveries. Many thanks to the team as well as to the families who participated in the early genetic and other research studies. If their participation enabled these new treatments and breakthroughs." So again, on behalf of the presenters and the Evenings with Genetics program, thank you all for attending tonight's webinar. We appreciate your time and hope this session has shared some new information and experiences with you. Please look for a survey email tomorrow where you can share your thoughts and your ideas for future presentations. And good night.